So first of all, I'd like to welcome everybody to the National Pancreas Conference. We've worked really hard. We have some amazing speakers and topics that we've already addressed, and we have some coming up today, of course. And we hope that everyone takes something away from this National Pancreas Conference that you can apply in your practice. I'd like to introduce two wonderful speakers. The first is Professor Dominguez-Muñoz. He's a professor of medicine and director of the Department of Gastroenterology and Hepatology at the University Hospital of San Diego de Compostela, Spain. I hope I got that right.
You did it perfectly.
He was trained in Madrid and became a specialist in internal medicine and gastroenterology in Germany. He is the editor of 12 books and author of 292 papers in peer-reviewed journals and 96 book chapters. He acts as invited reviewer of the most relevant scientific journals in the fields of gastroenterology, and he is frequently part of the invited faculty of international scientific meetings. His main areas of interest are pancreatic diseases, pancreatic function, and exocrine pancreatic insufficiency. We also have with us Popi Kasvis, and she is a clinical nutritionist and dietitian at the McGill University Health Center in Montreal, working within the Disciplinary Cancer Rehabilitation Program, which is CARE Pro. Briefly, her clinical duties include assessing patients for the presence of malnutrition, sarcopenia, and cachexia, creating a nutritional treatment plan to optimize nutritional status and managing nutrition impact symptoms. So in this session, we'll discuss any patient with cancer, including pancreatic cancer at any stage of disease and into survivorship may be referred to CARE Pro. Popi is also a PhD candidate in the Department of Health and Exercise Science at Concordia University. Her research is focused on the efforts of early diet and exercise interventions on the health-related quality of life of patients with pancreatic cancer undergoing both curative and palliative treatments. I'm just going to admit this in this session. We know that the pancreas is critical for the digestion of food, absorption of nutrients. So when pancreatic cancer is compromising the organ's function, pancreatic enzyme insufficiency can occur. Most cancers are associated with weight loss, so the additional burden posed by the reduction of digestive enzyme production amplifies the symptom for pancreatic cancer patients, and the lower nutritional intake reduces their body's ability to tolerate aggressive treatment or fight the disease. Pancreatic enzyme replacement therapy replenishes the important enzymes that the pancreas is unable to produce efficiently. This session will educate participants on current best practices involving pancreatic enzyme replacement therapy and highlights its impact on improving patient outcomes.
Thank you very much for inviting me to be today with you. It's a pleasure to be part of this pancreas conference and to talk about pancreatic exocrine insufficiency and pancreatic enzyme replacement therapy. And you should be aware that the severity of weight loss and malnutrition makes pancreatic cancer different. Pancreatic cancer is a different tumor. You know that the majority of the patients, up to 80% of the patients, present with a significant weight loss of more than 10% of the usual body weight at the time of the diagnosis of the disease. And the majority of the patients develop sarcopenia and cachexia during follow-up. And you should know that pancreatic cancer shows the highest rate of sarcopenia and cachexia among all malignancies. So malnutrition is a critical factor in the poor prognosis of patients with pancreatic cancer. And this is something that we need to know. Malnutrition is associated with an increased risk for hospitalization and a longer hospital stay, risk of complications, more immortality, and a poor performance status and quality of life, a poor tolerance and response to any oncological treatment, and a shorter survival. So malnutrition, again, is a key factor in the poor prognosis of patients with pancreatic cancer. Obviously, malnutrition is a multifactorial condition. First of all, you know very well that patients with pancreatic cancer have a very limited food intake. And this is, again, multifactorial. So the patient has cachexia, anorexia, early satiety. Not only that, the psychological situation with depression, anxiety, abdominal pain, diarrhea, nausea and vomiting, and the inflammatory response to the tumor all together makes that the patient with pancreatic cancer tend to have a very limited food intake. But not only that, patients with pancreatic cancer develop pancreatic exocrine insufficiency, leading to maldigestion of nutrients and malabsorption of nutrients. So it is a kind of situation of being fasting. They are eating not much, but they cannot digest and absorb what they eat. This is the situation in pancreatic cancer. What are we talking about? I would like to hide what I have here, but anyway, I will leave it that way. It's safer. So what are we talking about when we talk about pancreatic exocrine insufficiency? First of all, we are talking about a primary or secondary disturbance of the exocrine pancreatic function at a level that prevents normal digestion of food. So maldigestion leads to malabsorption of nutrients. And as a consequence, patients may present with PEI symptoms and nutritional deficiencies. When we talk about PEI, we are talking about maldigestion, malabsorption, malnutrition of patients. Look, how do patients with pancreatic cancer develop pancreatic exocrine insufficiency? Here we need to consider two different scenarios. First of all, patients with a tumor in situ. That means patients before surgery, patients on neoadjuvant therapy, or patients with non-resectable pancreatic cancer. And a different scenario are patients after surgical resection, either after pancreatic duodenectomy or distal resection, left resection of the pancreas. What about patients with a tumor in situ? We know, and this is a meta-analysis that was published by our group last year, we know that 72% of the patients with pancreatic cancer develop pancreatic exocrine insufficiency. So 3 out of each 4 patients with pancreatic cancer present with PI, maldigestion, malabsorption of nutrients. You may see here a quite nice difference among different studies. You know why is that? There are different factors explaining that, but one of them is that different studies use different methods to diagnose pancreatic exocrine insufficiency. And here, I would like to introduce you the C13 MTG breath test, because by far is the best method to evaluate digestion and absorption of nutrients. Look, it is based on the oral administration of C13 MTG. MTG is a triglyceride, which is C13 labeled. You know that C13 is a stable isotope. It can be used in children. It can be used in pregnant women, for example. We give it together with a test meal consisting in toast and butter. And once the substrate is emptied from the stomach, it is specifically digested by pancreatic lipase. After digestion, it is absorbed, metabolized in the liver, and as a result of the liver metabolism, certain CO2 is released and exhaled in the breath. And interestingly, the amount of C13O2 that we are able to recover in the breath from the amount that we gave orally represents how much fat was digested by the pancreas in the gut. So this is a very elegant way to evaluate fat digestion. Look, this is the result of the breath test. And here you can see in blue what is normal. This is the recovery rate, a fully normal curve of the recovery rate, C13 recovery rate in healthy people. And you can see in red what is the recovery rate, that is how much a patient with pancreatic cancer is able to digest. And you see how huge is the difference. Considering that steatorrhea means less than 29% of the C13 that we are given orally being digested and absorbed, 80% of the patients with pancreatic cancer with a tumor in the head of the pancreas present with PEI, maldigestion, malabsorption, and steatorrhea, 80% of them. Why can patients with pancreatic cancer develop pancreatic exocrine insufficiency? Look, there are mainly 2 factors. First of all, the tumor may obstruct the main pancreatic duct. And secondly, and this is something that probably you are well aware of, is that the pancreas proximal to the tumor becomes markedly atrophic. So parenchymal atrophy and obstruction of the main pancreatic duct may be the reasons why a patient with pancreatic cancer may develop pancreatic exocrine insufficiency. And you can see here in two CT scan figures what I'm talking about. This is a patient with a tumor in the head of the pancreas, and you see the duct markedly dilated, proximal to the tumor, and the parenchyma in the body of the pancreas markedly atrophic. And here, another example with a tumor in the body tail of the pancreas, dilation of the proximal duct to the tumor, and atrophy of the parenchyma. We wanted to know whether obstruction of the main pancreatic duct is the main reason for PEI in patients with pancreatic cancer, because this is critical in order to treat these patients properly. And what we did was a double-blind, prospective, randomized, single-center interventional study of patients with obstructive jaundice, and therefore with an indication for ERCP to drain the bile duct, secondary to non-resectable pancreatic cancer. These patients with a tumor in the head of the pancreas obstructing the main bile duct, the common bile duct, were randomized to receive just a biliary stenting, and as you can see on the left, or a double stenting, biliary stenting and pancreatic stenting, just to allow pancreatic secretion to drain. What we did was to evaluate by means of the breath test, digestion before stenting and 2 weeks after stenting. This is a paper that we have published a few months ago. And you can see the final result, which is very important in order to understand the management of these patients. Look, in red, you can see digestion in the same way I told you before using the breath test. Digestion before stenting, you can see that in the two groups of patients, that curve is very similar, markedly reduced compared to the healthy situation that I showed you before. And in blue, in the left graphic, after biliary stenting, nothing happens at all. So biliary stenting brings nothing, no benefit at all in terms of digestion. However, when we add also a pancreatic stent, allowing for pancreatic secretion to reach the duodenum, you can see how nicely digestion improves after double stenting, biliary pancreatic stenting. The majority of the patients were able to normalize digestion. So after that study, I can tell you that PI in patients with pancreatic cancer is mainly an obstructive complication that can be treated by stenting the main pancreatic duct. Look, taking that into account, you have here a patient with a tumor in the body of the pancreas. You can understand that the head of the pancreas is healthy, is producing enzymes, is secreting enzymes into the duodenum, and therefore these patients may secrete a sufficient amount of pancreatic enzymes and bicarbonate to digest food. At least this is a possibility. However, if the tumor is located in the head of the pancreas, in that case, there is no parenchyma able to secrete enzymes into the duodenum, and that those patients will present with a high probability with pancreatic exocrine insufficiency. That means the closest the tumor is located to the duodenal wall, the lower the pancreatic secretion, and therefore the higher the probability of pancreatic exocrine insufficiency. And that's an important information to understand why patients with pancreatic cancer develop pancreatic exocrine insufficiency. And that explains why in the meta-analysis that I showed you before, patients with a tumor located in the head of the pancreas have 3.36 times higher risk to develop PI compared to patients with a tumor in the body or tail of the pancreas. So the second scenario are patients after pancreatic duodenectomy. So patients after surgical resection of the pancreas when the tumor is located in the head of the pancreas. And you can see here the picture of a pancreatic duodenectomy, the situation after surgery with a wide and roux reconstruction, gastrointestinal reconstruction. These patients develop PI due to different reasons. First of all, Of course, part of the pancreas has been resected. The head of the pancreas has been resected. And as I told you before, the remaining pancreas is atrophic, is not healthy at all. Therefore, these patients have a markedly reduced capacity for exocrine secretion. Not only that, the duodenum has been resected, and the duodenum and proximal jejunum is the place where CCK and secretin are released. Therefore, these patients have a markedly reduced postprandial stimulation of the pancreatic secretion due to a reduced release of CCK and secretin. And not only that, the duodenum and proximal jejunum is the place where the enteropeptidase is produced. And you know, enteropeptidase in the intestinal lumen is responsible for the activation of the proproteases secreted by the pancreas, trypsinogen to be activated to trypsin. Therefore, they have also a markedly low activation of proteases in the gut. And not only that, after the intestinal reconstruction, there is an asynchrony between the gastric emptying of nutrients coming down through the efferent loop and the biliopancreatic secretion coming down through the afferent loop in a way that it is impossible that the enzymes and the food mix properly to be digested properly. So if you put everything together, you should understand that it is absolutely impossible to digest food normally after pancreatic duodenectomy and intestinal reconstruction as that one. Actually, there are systematic reviews showing that after pancreatic duodenectomy, 92% of the patients develop pancreatic exocrine insufficiency, almost everyone. What about distal pancreatectomy when the tumor is located in the body or the tail of the pancreas? I must tell you that according to what has been reported in the literature, up to 80% of the patients develop pancreatic exocrine insufficiency, depending on how much pancreas is still remaining. And there is a very interesting Japanese study published already 5 years ago, showing that if the remnant pancreatic volume is smaller than 24 milliliters, this is associated with PI with a high hazard ratio, close to 6. So it depends on how much pancreas is remaining after surgery. So I hope that you understand now that PI is a very frequent complication of pancreatic cancer, and it is also depending on whether the tumor is located, where is the tumor located, and what is the surgical procedure. Now the point is, what is the consequence of PI? The slide that I'm showing to you now is the evidence that we have in different pancreatic diseases, not only pancreatic cancer, also chronic pancreatitis. And look, pancreatic exocrine insufficiency leads to symptoms of malabsorption and therefore to poor quality of life and to nutritional deficiencies. And what you can see here is the typical biochemical profile of patients with pancreatic exocrine insufficiency. They have low circulator levels of essential amino acids, fatty acids, proteins, lipoproteins, micronutrients, antioxidants, and fat-soluble vitamins. All of this leading to a high risk of bone disease, muscle loss, sarcopenia, cardiovascular disease, and mortality. Talking specifically about pancreatic cancer, in patients with pancreatic cancer, the development of pancreatic exocrine insufficiency is a relevant cause of weight loss and malnutrition. It is associated with a poor quality of life. And look, pancreatic exocrine insufficiency is an independent and significantly associated factor with a short survival. So now the key question is, okay, now you know not only that PI is very frequent in pancreatic cancer, you know how does it develop? Not only that, you know that it's very relevant, highly relevant. The question is, how can you know if the patient sitting in front of you with pancreatic cancer has or not pancreatic exocrine insufficiency? How to diagnose pancreatic exocrine insufficiency? And I will show it to you very practically. Look, if when you see the patient has lost more than 10% of the body weight, so a significant weight loss, this is almost always associated with pancreatic exocrine insufficiency. You don't need any test. That's PEI. Not only that, if that patient has a tumor located in the head of the pancreas with proximal dilatation of the main pancreatic duct, that telling you the pancreatic duct is obstructed, that is a clear sign of pancreatic exocrine insufficiency. And surgery. I told you before, almost every single patient after surgery develop PI after pancreatic otodenectomy, total or subtotal pancreatectomy. In all these three clinical situations, you don't need any pancreatic function test. You can go directly to the treatment because these patients have for sure pancreatic exocrine insufficiency. In the remaining situation, that means patients with a tumor located in the body or tail of the pancreas, or patients after surgical resection of the body or tail of the pancreas, left resection, you can make the diagnosis of PI very easily by evaluating these three different domains: symptoms of maldigestion, diarrhea, flatulence, abdominal distension, abdominal cramps, weight loss; nutritional evaluation, including anthropometry and biochemical nutritional markers; and a pancreatic function test, usually fecal elastase, which is the test that is widely available worldwide. Look, if all these three domains are abnormal, that means symptoms are there, nutritional deficiencies are there, and an abnormally low fecal elastase test is there, or at least two of these three domains are there, that makes the diagnosis of PI very likely. I will tell you nothing about nutrition because this is the topic of the next presentation, but let me tell you something about symptoms and about fecal elastase. Look, if your patients with pancreatic cancer cannot digest the total amount of carbohydrate that they eat, they will present with symptoms of carbohydrate malabsorption, which are mainly dominated by gas production, as you know. Therefore, they will present with abdominal distension, flatulence, abdominal cramps, diarrhea. If they cannot digest the total amount of fat and protein that they eat, they will present with diarrhea. But there is something that you should know. All the patients with pancreatic cancer have a certain capacity to digest food, markedly reduced, but still there, some capacity to digest food. If they adapt the diet in order to not to overcome the digestive capacity, they will not present any symptom at all. They may be symptom-free if they adapt the diet. So what I wanted to tell you is that the amount of ingested food should exceed the digestive capacity of the exocrine pancreas for symptoms to develop. And it is not rare at all, it is not infrequent at all to have patients with PI who are symptom-free because they have adapted the diet, mainly reducing fat intake. The second point that I wanted to tell you is about fecal elastase. You know what is pancreatic elastase? It's a pancreatic specific enzyme. It's stable during the GI transit. This is very important because what we can measure in feces reflects quite nicely what the pancreas had produced. So it's very easy to quantify. You only need a small sample of feces. And the enzyme is stable in that sample for 1 week at room temperature. That means that you can send the sample to any reference lab if you need it for quantification without the need of refrigeration, which is making the test very simple, very easy. Two drawbacks. First of all, if you measure fecal elastase by yourself, you will see that today you don't have the same concentration than tomorrow or 1 week later. So there is an individual variability that you should take into account. Not only that, there is no specific cutoff to diagnose pancreatic exocrine insufficiency. What I can tell you is that the lower the fecal elastase concentration, the higher the probability of PEI. Very low concentrations below 50 microgram per gram are specific but not sensitive for PI. Higher concentrations are more sensitive but are less specific of PI. Do you know already that the patient sitting in front of you has pancreatic exocrine insufficiency? How to treat it? 2 pillars, dietary advice and nutritional support. Obviously, I will say nothing about it. This is the topic of the next presentation. And pancreatic enzyme replacement therapy. What is the aim of the therapy? Obviously, to avoid symptoms, if symptoms are there, to avoid symptoms, nutritional deficiencies, and mainly to avoid the malnutrition-related morbid mortality. Therefore, our aim is to ensure a normal nutritional status as much as possible. Let me show you what is the summary of the evidence with pancreatic enzyme replacement therapy. In that slide, I must tell you that I include not only studies in pancreatic cancer, but also in other clinical conditions like chronic pancreatitis. But what I can tell you is that by pancreatic enzyme replacement therapy, we can improve digestion and absorption of nutrients in our patients. We can improve the nutritional status and the body weight, quality of life, and survival. And we can limit maldigestion-related symptoms. We can relieve symptoms, diarrhea, flatulence, abdominal distension, cramps, weight loss. We can avoid malnutrition-related complications and to reduce mortality. This is what we can get or we can obtain by pancreatic enzyme replacement therapy. Very few studies that I want to show you. This is a small study, quite old already. Only 21 patients being included, short follow-up, just 8 weeks. But in that study, I can tell you that patients who were on enzyme therapy were able to gain weight. These are patients with non-resectable pancreatic cancer, whereas patients who were on placebo continued to lose weight. So we can stop weight loss and even increase body weight by prescribing enzymes in patients with pancreatic cancer. Another important study, this is a qualitative inquiry framework to explore patients' perspectives and experience regarding pancreatic enzyme replacement therapy. And what the patient said is that that therapy was associated with weight gain and lack of weight loss and relief of symptoms, relief of pain, diarrhea, and other abdominal symptoms. And what the authors conclude is that pancreatic enzyme replacement therapy, and of course, always the associated dietary advice, resolve symptoms of malabsorption and markedly improve quality of life. And therefore, according to these authors, for people affected by pancreatic cancer, this is an essential supportive care. Look, that paper was published 8 years ago. 8 years ago, were not so many centers prescribing pancreatic enzymes in pancreatic cancer. And this is our study that we published 3 years ago. What you can see here is the survival. I'm not talking about symptoms. I'm not talking about quality of life. I'm talking about survival of patients with non-resectable pancreatic cancer, the majority of them metastatic disease. According to whether they receive or not pancreatic enzyme replacement therapy, I have included in that figure only patients who had a weight loss higher than 10% of the usual body weight before the diagnosis of the disease. So a significant weight loss. And you can see the highly significant difference in survival between those who were unpaired compared to those who were not receiving pancreatic enzyme replacement therapy. And if you consider that time point, which is about 1.5 years from the beginning from the diagnosis, you can see that almost no single patient who did not receive pancreatic enzymes was still alive. However, about 20% of the patients who were unpaired were still alive. I'm talking about metastatic disease, which is not so bad. And this is obviously highly significant. Look, we did a multivariate analysis, and metastatic disease was associated with a shorter survival, and there were only 2 factors significantly and independently associated with a longer survival. And these 2 factors were chemotherapy and pancreatic enzyme replacement therapy. This is a study from UK, very nice study. What you can see on the left of this vertical dotted line means that these factors are associated with a shorter survival. That means age, comorbidities, and smoking are associated with a shorter survival in patients with pancreatic cancer. Those factors on the right of this vertical dotted line are associated with a longer survival. And here you can see surgery, chemotherapy, and pancreatic enzyme replacement therapy. And if you see the survival time ratio, it is very similar in all these three factors. That means the impact of pancreatic enzyme replacement therapy is similar in terms of survival to surgery and to chemotherapy. And this is probably the most important slide of this study from UK. Again, what you see, this is the impact of pancreatic enzyme replacement therapy on survival, by the way. Everything that you see on your right, on the right of this vertical dotted line, means that it is associated with a longer survival. And as you can see, everything, always, pancreatic enzyme replacement therapy is associated with a longer survival in patients with pancreatic cancer. I don't care whether the patient is a male or female, young or old, with or without comorbidities, smoker or not, receiving chemotherapy or not, being operated or not. PERT is always associated with a longer survival. So I'm coming to the end. I wanted to show you how frequent is PI in pancreatic cancer. What are the mechanisms of PI so that you understand why these patients develop PI? I wanted to show you how relevant is PI as a poor prognosis factor in these patients and how to diagnose this complication and what is the impact of therapy. Now, how to take that therapy. Look, according to guidelines, oral pancreatic enzymes should be taken distributed along with meals and snacks. And that comes from that study from our group, already quite old. This is a prospective control crossover design in a way that all the patients took the enzymes in three different ways: before the meal, after the meal, or distributed along the meal. All the patients did all of these three protocols, taking 40,000 units of enzymes of lipase with main meals. And as you can see that taking the enzymes along the meal, during the meal, is associated with a higher proportion of patients that are able to normalize digestion according to the breath test. So this is the way to take the enzymes, not before, not after, but during the meal. What is the correct initial dose to start with? Look, what we recommend in diseases like chronic pancreatitis is an initial dose of about 50,000 units with main meals, half that dose with snacks. I should tell you that that dose is not enough for patients with pancreatic cancer or after surgery, and the initial dose should be at least about 75,000 units with main meals, about 50,000 units with snacks, always associated with a proton pump inhibitor. Twice a day, before breakfast, before dinner. These patients do not only have a markedly reduced secretion of pancreatic enzymes, but also of pancreatic bicarbonate, in a way that the pH in the gut is acidic. At that pH, pancreatic enzymes are not effective. If this is not enough, if that dose is not enough, we should increase the dose as needed, obviously together with the nutritional support to achieve weight gain and improve nutritional status. What are the messages I would like you to take home? First of all, PI is a frequent complication of pancreatic cancer and pancreatic surgery for cancer. PI is associated with symptoms, nutritional deficiencies, and weight loss, leading to poor quality of life, poor tolerance and response to any tumor therapy, complications, and short survival. The development of PI is the rule in patients with a tumor obstructing the main pancreatic duct at the head of the pancreas, as well as in patients after pancreatic duodenectomy, obviously after total pancreatectomy. In other clinical scenarios, the diagnosis of PI requires the evaluation of symptoms of malabsorption, as I told you before, nutritional status, and fecal elastase test. The treatment of PI is based on nutritional support and oral pancreatic enzymes that should be taken along with meals and snacks. A proton pump inhibitor is always needed in these patients. It is not what we do in chronic pancreatitis, but it is what we need to do in pancreatic cancer associated with PERT to ensure the release of pancreatic enzymes in the proximal gut and therefore the efficacy of pancreatic enzyme replacement therapy. PERT leads to symptom relief, improved nutritional status, weight gain, improved quality of life, better tolerance to tumor therapy, and increased survival in pancreatic cancer. Initial dose of about 75,000 units is recommended with main meals, half that dose, or about 50,000 units, with snacks. And finally, in case of insufficient response in terms of weight gain and normalization of the nutritional status, the enzyme dose should be increased together with the nutritional support to achieve weight gain and improve nutritional status. So thank you very much. This is what I wanted to show you today. And I wanted to bring you some picture from our city, from Santiago de Compostela. It is a very nice city, as you can see. And therefore, I wait for you here. You should visit us. You should visit the city and visit us. And I tell you something, in 3 years from now, shorter, 2 years and a half from now, 2024, the annual meeting of the European Pancreatic Club will be held in Santiago de Compostela. So I wait for you all. Thank you very much for your attention.
Wow, I'm so pleased to have the opportunity to talk to you all. And I'm so excited by everything that Dr. Dominguez-Muñoz just said. Of course, in my case, I think he's preaching to the choir, but so fascinating, the role of PEI and PERT in our patients. And now I'll tell you as a nutritionist what I could do when these patients are actually receiving their PERT and actually absorbing their nutrients and maintaining or gaining weight. So first of all, I have no conflicts of interest to report. What I would like to do is just to start with a little icebreaker. So I've created this little poll for you all to answer 3 questions. Okay.
Yeah, so you ask.
So how many of you all have nutritional screening for all oncology patients coming through your center? So malnutrition screening tool that all patients just, answer. Could be anything. All right, so I think there are about 5 or 6.
Yeah, we have 1, 2, 3.
I think the hands go down eventually.
We had a little bit, yeah, the hands went down, but we had about 5 or 6.
Yeah, so about a quarter of the participants here.
Yeah.
So the next question, how many of you have a dietitian who's embedded in like an HPB clinic or a clinic, whether it's surgical or oncological, that deals with pancreatic cancer?
1, 2, 3.
And it seems to be some of the same people who are screening, which is interesting.
Yeah.
Mm-hmm. Okay, so the last question, and maybe you guys, if you're willing to just type a quick word into the chat, but how many, or sorry, when do the nutritionists actually first see the patients, whether they've been screened or just referred to? Is it at diagnosis? Is it after surgery? Is it before starting chemo or during chemo radiation? Or is it when it's too late?
We have 1 during treatment.
Any of the above?
There is it any of the above? At first with medical oncology.
Wow.
Yeah. During treatment usually. Okay.
So I think that's a great way to start the chat. And this wasn't in any way meant to shame anyone. I'm going to show you what we do at the MUHC. We're not perfect. So we do screen, but we're only screening patients who are receiving intravenous anti-cancer treatments. So for example, the surgical patients are not being screened. Patients receiving oral chemotherapy are not being screened. So this is a real limitation. We're working on changing that. The dietitian is not currently embedded in our pancreatic cancer clinics. My colleague Olga Grafer, who's in the audience today, is working very hard on changing that. And the majority of our patients are seen during their 2nd cycle of chemotherapy, which I would suggest is way too late. Way too late, especially after what we just saw from Dr. Dominguez-Muñoz. So we're not perfect, and we're working on trying to get up to standards, better standard of care. And as Dr. Dominguez-Muñoz said, malnutrition is such a problem in these patients. muscle wasting at diagnosis in up to 2/3 of these patients. And actually at diagnosis, up to 80% of patients could actually have cancer. Yeah. So it's really a big problem. And, you know, we get our patients into this cycle where they're eating less, they have anorexia, they lose weight, they lose muscle, they become more fatigued, they can't do their ADLs, IADLs, functional capacity just decreases, and their quality of life decreases. And you have to question, well, what are we doing? Because allowing this to continue just means to poor treatment tolerance, poor overall survival, and especially in those patients when you're considering we're giving them palliative chemotherapy to prolong their life and to improve the quality of life, well, then these nutritional issues have to be dealt with as soon as possible. So early intervention for the malnutrition in pancreatic cancer is key. And there were actually 3 publications just this year talking about this, not only for pancreatic cancer, but for cancer in general. So ESPEN put out guidelines this year, ASCO, as well as ESMO, talking in particular about cancer cachexia. And all 3 agree early intervention is key. And all 3 agree that all patients with cancer should be screened for malnutrition. And there are a plethora of screening tools. I'll just show you a couple right now. The most simple, the malnutrition screening tool on the left, it's literally 2 questions. Have you lost weight? How much weight have you lost? And are you eating poorly? Do you have a decreased appetite? And that simple tool could be used to flag a consult with a dietitian. Another tool widely used, the NRS 2002, will combine these concepts seen in the MST, but as well the disease severity. So it's not cancer specific. Disease severity and age would be a reason, or sorry, some of the etiologies of malnutrition. More towards oncology specific tools, we have what we use at the MUHC. I have a bias towards this one, the abridged patient-generated subjective global assessment, which is part of the gold standard of malnutrition screening in cancer, the patient-generated subjective global assessment. And I'm going to go through this tool a little bit more in depth later on. And then we have a more recent tool, the Nutri-Score, which is really a combination of those 2 questions of the MST, in addition to where is the cancer and what is the treatment plan for the cancer, which again could all lead to poor nutritional outcomes. So once we have a screening tool in place and the patient has filled out, if they are at positive risk for malnutrition, there should be a referral to a dietitian, and ideally a dietitian embedded within a multidisciplinary team to provide supportive care to these patients. Nutritionists we could do a lot of things, but there are certain things that need medical management as well. So we'll be able to talk about that as I go on. So what is our role in assessing these patients? Well, the dietitian will be able to confirm and grade the presence of malnutrition. So using a tool such as the PGSGA or the GLIM, we could identify reversible causes of malnutrition. So if PERT hasn't been prescribed, and we know, as Dr. Dominguez-Muñoz said, the tumor's in the head of the pancreas, there are obvious signs and symptoms of PEI, well, we could flag it. We'll look and see, is there new diabetes? Is glycemia well controlled? What are the nutrition impact symptoms? Are supportive medications prescribed? Is the patient taking their medications? What is their food intake? Is it adequate? Are they on some sort of crazy fad diet that is causing weight loss because they're just trying to, I don't know, do intermittent fasting or do a ketogenic diet, and they've changed their intake in a great way? So all these things are flags for a dietitian to say, ooh, this is a cause of malnutrition, it's likely reversible. A dietitian will also assess loss of muscle and fat mass. We could use hand grip dynamometry to assess dynapenia. All these part of an overall, diagnosis of sarcopenia. And then we could describe the etiology of the weight loss. So is it starvation versus cachexia? And I just wanted to give a little word on cachexia because it was of interest to some of our attendees today. So this is the definition that was put forth back in 2011 by an international committee headed by the guru of cancer cachexia, Ken Fearon. And I'm not putting this up here to quiz you at the end, but I just want to point out how complex cachexia is. It is a multifactorial syndrome, and it's categorized really, now we know more, by loss of both muscle and fat, and it cannot be reversed by conventional nutritional support. So I could put a feeding tube in you and offer a hypercaloric enteral feeding protocol, and it will not change the weight loss. And of course, as the patient loses weight, loses muscle, they lose function. They are less able to perform their ADLs. And this is really categorized by a negative protein and energy balance. And it's driven by the anorexia these patients are experiencing and the abnormal metabolism of nutrients within the patient. And I just wanted to show you, again, another guru of cancer cachexia, a Canadian, Vicky Baracos, who published back in 2018, The Pathophysiology of Cancer Cachexia. And in her paper, this cartoon was included. And just again, to point out the complexity of cancer cachexia, it's not just losing weight. It's really about tumor-derived tumor kinds, essentially, that are causing catabolism within the patient, but as well that host and tumor interaction, which just causes a pro-inflammatory, tumor-induced systemic inflammation. And this inflammation really targets many organs, okay? So it's within the brain and the appetite centers in the hypothalamus. It's within the muscle, the adrenal glands, the fat, the adipocytes, which start futile cycling of energy. So it's a very complex issue. And what we want, even with cachexia, just like malnutrition, is to catch it at its early stages. So back to Kenneth Fearon's article, there are 3 stages of cancer cachexia. So pre-cachexia, which is really categorized by mild weight loss, there is the presence of anorexia and the start of metabolic changes. Then we go into cachexia. And this is categorized really by a more pronounced weight loss in the context of anorexia and inflammation. You could imagine a cachectic patient would, at diagnosis, who has yet to receive any treatment, so not have surgery to remove the tumor, has not started any neoadjuvant or palliative chemotherapy. So the inflammation is all over the place until they start to respond to the therapy and then possibly decrease that inflammation. And then we could actually work to reverse this. So we could work to, the patient's appetite will improve, they'll be able to eat and stop the weight loss. So we could think of pre-cachexia and cachexia as points within this continuum and where we could reverse the malnutrition. However, once we get into refractory cachexia, this is where performance status really decreases. These patients are more often than not pretty much bedridden, and the prognosis at this stage is very limited, and it is not reversible. Again, put that tube in, I feed you, nothing will change. So it is a continuum, and early intervention is important, and understanding where we are within the cachexia continuum is important. So I just want to outline what a nutrition intervention may look like in a patient with pancreatic cancer who doesn't have cachexia or has pre-cachexia or cachexia. So we're looking at, these are the guidelines by all the major societies right now: energy intake of 25 to 35 kilocalories per kilogram per day, protein intake 1 to 1.5 gram per kilogram per day. And again, sort of going back to what Dr. Dominguez-Muñoz said, we want small, frequent meals, not to exacerbate, not to overload the pancreas, smaller meals that the patient could digest and hopefully absorb completely. We may suggest supplementation, although it's not the only thing we do. So oral nutritional supplements, semi-elemental formulas, which are already sort of pre-digested and much more easily absorbed in a patient whose pancreas is not working properly and has PEI. We'll need to have some fat-soluble vitamin replacement, multivitamin replacement as well for some of the micronutrients. We may choose to use medium-chain triglycerides just to increase caloric intake. And then whey protein, which is important because of its elevated leucine content, to really promote anabolism in a very catabolic scenario, and to protect muscle mass, which is important to maintain function and to actually tolerate chemotherapy. We'll also deal with nutrition impact symptoms. We will give dietary counseling and advice on how to deal with anorexia or satiety, dysgeusia. I mean, the list is there, but it goes on. We'll analyze and see what's going on with their bowel movements and some of those unfortunate outcomes from malabsorption. And then I would like to argue, will be the champions of PERT. If the patients are not on PERT, we will push, or we should be in the position to push to get it started. We could help with the titration of the dose based on intake, symptoms, how the patient is doing, how they're feeling after eating. And we want to make sure that the patient is using it properly and adhering to the protocol. So I've had patients that come in and they say, well, you know, I took my enzymes 20 minutes before my meal and then I ate and then I felt really bad afterwards. Well, you know, they might not be telling this to their oncologist, their nurse, but I'll dig and find out, and, you know, we could actually adjust how the patient is using their enzyme replacement therapy. Because if they're going to go to the trouble to take all these capsules, we want to make sure that it's being used appropriately. So I want everyone to go home thinking of their dietitian as their PERT superhero. And hopefully, you know, the oncology team will count on the dietitian to really be monitoring the effect and the adequacy of the PERT. And just to sort of harp on this a little bit, there was just last month this large UK prospective study that analyzed data of 1,335 patients with pancreatic cancer. And they were looking at sort of reasons, you know, how or when PERT was being prescribed to patients with pancreatic cancer. So, of course, what I focused in on was all the stuff about the dietitian. So when patients were referred to a dietitian, 77% came out with a PERT prescription, whereas 20% came out with a PERT prescription when they did not see a dietitian. So that's a huge difference and highly significant, as you could see here. Then they looked at a multivariate logistic regression to see in surgical candidates when they were referred to a dietitian, 87% received a PERT prescription. And this was an odds ratio of 3.78-fold, where seeing a dietitian meant you would have PERT. In terms of the non-surgical patients, again, 70% of patients who saw the dietitian received a PERT prescription, and it was a 3.43-fold odds of being prescribed PERT when they saw the dietitian. Now, of course, we weren't clinical specialists as well. However, in the surgical candidates, there was no significant increase in PERT prescription when seeing the nurse. In the non-surgical candidates, yes, there was a 1.68 increase in the odds that they would receive PERT when seeing the nurse, but that's not as good as it is with the dietitian. Remember, we are assessing everything that goes in and everything that's coming out of the patient, so this is really our role. Okay, so continuing on into our intervention, of course, we will be looking at diabetes if these patients are newly diabetic or have a recent diagnosis of diabetes that comes often with pancreatic cancer. We'll optimize glycemic control, not necessarily only through diet, of course, looking at diet, but depending on what the patient is actually eating, we might be championing for adjustments to their insulin or OHAs. And then, of course, for the patients who can't eat, nutrition support. So enteral nutrition, of course, is the first choice. We want to maintain gut function and gut integrity. Of course, if there's significant GI dysfunction, any sort of obstruction, we might then consider parenteral nutrition. But all the guidelines agree that this is only appropriate in patients with a prognosis more than several months and who are still receiving anti-cancer treatments. If a patient is, close to dying or coming towards end of life, it is no longer necessarily ethical to provide nutrition support. So it really is a case-by-case basis. Now, going back to our cachexia stages, for those in refractory cachexia, oftentimes we don't think of nutritionists being involved in these patients' care, but I would like to argue that absolutely we do have a role. It's just not the traditional one. So our nutrition intervention is going to really focus on comfort care, quality of life. In the guidelines by ESMO, they talk about the nutritionist's role in providing education of cancer cachexia, explaining what it is. I know in my practice, this is very anecdotal, but oftentimes patients don't know, have never heard of cancer cachexia, and we discuss it. We discuss the relationship with anorexia and why the anorexia is occurring in these patients. And all that is in the hopes of alleviating eating-related distress, which is so common in patients with pancreatic cancer who are trying. It is so common in their caregivers who are really trying to feed this patient who just does not want to eat, cannot absorb. So the goal, our goal as nutritionists is really to try to deal with these more psychological issues coming towards the end of life and providing comfort care. So I just want to take a little moment to talk about that whole idea of multidisciplinarity in the care of patients with cancer, patients with pancreatic cancer, and how a nutritionist is likely most effective working within a multidisciplinary team. So I'd like to present to you the cancer rehabilitation program at the McGill University Health Center where I work. This is, again, a team that sees all our cancer patients, including those with pancreatic cancer, and we work together rather than in silos, which is what usually happens, to give best supportive care to both the patient and their caregivers. So in our team, we have a physician who's a supportive care, palliative care physician, a nurse, an occupational therapist, a physiotherapist, and myself. And I'm just going to talk about how within our clinic, we distinguish between malnutrition and cachexia. So as I promised before, we're going to go back to my little bias here about using the abridged patient-generated subjective global assessment. Again, this is a tool used for screening, but and I'll just go through what it measures. Okay, so first of all, it measures weight loss. So 6-month weight loss, 1 month weight loss, the patient reports what has happened and whether they're still losing weight within the last 2 weeks. So box 2 will look at food intake. Is the patient eating less than usual, more than usual, same as usual? Okay, so we could sort of already see, well, there's a decreased food intake. Box 3, excuse me, is the nutrition impact symptoms, and they could be anything from really gastrointestinal things, so dysgeusia, nausea, vomiting, constipation, diarrhea, but also fatigue, other things that are going to cause patients to eat less. So fatigue, pain, depression, it's all in here. And then number 4, we're really looking at performance status. So this is really the Eastern Cooperative Oncology Group Performance Status Scale. And the ECOG basically looks at function in terms of normal, no limitations. Well, not quite my normal self, but I'm still up and about and doing my things, to I'm in a chair for almost half of the day and then I'm bedridden. Okay, so really functional status. And a score, in the way this tool works, is really a score of 4 and above is really a flag for, yes, there's an issue here. And a score of 4 or 8, or 4 to 8, excuse me, in particular, would indicate an intervention by a dietitian in conjunction, as you could see, with a nurse or physician. So already we're thinking of that multidisciplinarity. And a score of 9 or more really means that, these nutrition impact symptoms need to be managed medically, and that dietitian has to play a role in helping that. So back in 2017, Dr. Antonio Vigano, who's actually the director of the Care Pro program at the MUHC, published this paper, and I invite you to read it. I'm not going to go through all the results. What I will ask you to look at is this table. And basically, this table is a way that we could use very available clinical tools to actually define the stage of cachexia our patient is in. And this will allow us to really be able to target our nutrition therapy and our multidisciplinary treatment appropriately. So the APGSGA is measuring all these things. We're looking at food intake, moderate or significant weight loss, and the decreased activities and functioning. And all we need to add to that is a lab test, which all our patients are going for 100 blood tests all the time. That includes something like C-reactive protein, an inflammatory marker to really confirm that presence of cachexia. And basically what the paper showed is here, pre-cachexia is the moderate weight loss, along with maybe abnormal biochemistry, maybe decreased food take. The cachexia is really when that weight loss becomes significant, okay? And they define it as 5% in the past 6 months. And we know, as Dr. Dominguez-Muñoz said, a lot of our patients are already coming in with pancreatic cancer with 10% weight loss. The refractory cachexia is all the markers of cachexia in addition to low performance status, so those patients who are bedridden. So already right there, we're able to sort of categorize and define what the stage of cachexia is. And we could start thinking in our heads, is this reversible or not? An example of what a multidisciplinary team would do. So the medical team would provide the supportive medication to treat reversible causes of malnutrition. So pain is primordial. If there is pain, there is no way a patient will eat. So pain control becomes very important. Then nutrition impacts symptoms. So I put, for example, here a prokinetic to deal with appetite loss or early satiety, but it could be a multitude of things. It could be optimizing the antiemetics the patient is taking. If they're constipated, someone asked about opioid-induced constipation, to provide laxatives, to provide PERT when the patients are not coming in already on pancreatic enzyme replacement therapy. A problem in cachexia in men is hypogonadism, and that just leads to fatigue. So testosterone replacement therapy might be something tried. And then for the inflammation itself, depending on treatments, comorbidities, other medications the patients are on, NSAIDs might be prescribed. I may recommend an omega-3 fatty acid. So it depends. So for the dietitian, as I mentioned before, we're looking at energy protein intake, management, nutrition impact symptoms. We're looking at PERT, of course, and supplements. The physiotherapist will, if the patient is able to, prescribe a low to moderate impact exercise regimen, and at the very least, reduce sedentary behavior. So rather than lying down, sit up. Rather than sitting, stand up every hour, walk around your coffee table, just to get the patient moving to maintain that muscle. And then the occupational therapist might work on fatigue, poor sleep hygiene, stress reduction. It really depends on what the patients are coming in with. But often she'll talk about pacing, energy conservation, deep breathing activities, muscle relaxation, just to help with the anxiety and depression, as Dr. Dominguez-Muñoz said, is very common in these patients. And our patients, there's no psychologist, unfortunately, embedded in our program, but there is one at the MUHC, and they're often referred to for psychological help. So I just want to leave you with this diagram from the Ahrens article in ESMO looking at the treatment of cancer cachexia. And we see our little box here with the dietitian nutritionist right next to supportive and palliative care physician, working to assess our patients, to provide proper nutrition support, and to diagnose and code things like cachexia, malnutrition, of course, also sarcopenia, which I didn't really have time to talk about today, but these are all things that we could involve ourselves in, champion for, and really work on hopefully reducing or at least maintaining the patient's status to ensure their quality of life. So I'd like to thank everyone for the invitation to speak today and for your attention.